represented by Professor Chu Young Lee. And Dr. Lee earned the
có. Ok.
South Korea, then British Orthodox President Program obtaining an master's degree in 1989 and received the his PhD degree in 1997. Dr. Lee was a president and currently an advisor of the Korean Society of Digital Orthodontists. He has served as a chief director of Plus One Orthodontics since 1992. And now, please give a big round to welcome Professor Chu Young Lee.
Now, it's good morning and good afternoon, everyone. I'm pleased that the 70th VIU is held in Ho Chi Minh City is in collaboration with WIUC. It is an honor to meet with many esteemed orthodontists from various countries, including Vietnam, during this opportunity. Today, I'd like to spread the new perspective on asymmetric occlusion and midline improvement. Specifically, I will discuss the collaborative role of temporomandibular and temporary anchorage devices and controlled pushing force in orthodontic treatment. Asymmetric occlusion and midline deviations can manifest in various clinical scenarios. These issues may arise from dental and skeletal discrepancies, or as a consequence of temporomandibular joint dysfunction. Let's begin with examining this case 1. This is an adult male patient who presented with a cheek complaint of pronounced lip protrusion. He exhibits the characteristics of class 2 subdivision asymmetric occlusion with a noticeable leftward with a deviation of the mandibular midline. The patient demonstrates significant protrusion of the incisors and lips with obvious resorption of the left mandibular condyle, likely contributing to asymmetric occlusion. To improve the lip protrusion, I started the treatment by extracting the premolars and retracting the anterior teeth distally. To correct the asymmetric occlusion, I extracted the mandibular second premolars on the lower left quadrant, while the other 3 quadrants underwent extraction of the first premolar and installation of tags. Despite these efforts, the midline improvement remained so fast, as there was a substantial extraction space on the left, which could exacerbate midline deviation. In the context of midline correction, what factors can we choose to improve the class 2 occlusion of the molars? What responses we can anticipate if we insert tags in the anterior region and utilize a conventional method to retract the molars. As noted in a recent JCO article, there may be side effects associated with this approach, such as major tipping of the molars and protrusion of the incisors. Professor Che illustrated the changes that occur when utilizing tags to protract the mandibular arch through finite element analysis. When the molars are protracted with tags, they tilt forward and become extruded, while with the incisors typically exhibit intrusion and protrusion. Thus, when employing TADs to pull the molar forward, we can anticipate a major tipping of the molars accompanied by intrusion of the incisors and subsequent tilt of the occlusal plane. Therefore, if one installs TADs in the anterior region and pull the molar forward to facilitate the forward movement of the mandibular molars in this patient, it is possible that extrusion of the molars and intrusion of the incisors may occur unilaterally, so resulting in a tilted occlusal plane in the anterior segment. The anterior-posterior issues of the molars can transform into vertical discrepancies of the incisors. How can we effectively avoid these interdimensional side effects? Instead of relying on pulling force, I can minimize these side effects by stabilizing the incisors with a segmented wire connected to the TADs and employing controlled pushing force. In case 1, I applied TAD-supported pushing forces by connecting the TADs to the mandibular incisor region with the segmented arches and utilizing an open coil spring, so we can successfully improve the midline. This pushing force system provides reliable anchorage, stabilizing the incisors even during the forward movement of the molars. Not that the mandibular midline has been overcorrected, so we can proceed with safely retracting the incisor teeth symmetrically while it's absently closing the remaining space. By harnessing TAD-supported pushing forces, we effectively establish a well-aligned mandibular midline and achieved class 1 occlusion of the molars. The protruded incisor and lid also improved to patient satisfaction. To construct this pushing force system, it's a TAD with aperture must be utilized. First, create the incisor arch using a segmented wire and subsequently connect to the TAD hole. Thereafter, apply force with an open coil spring. Many manufacturers provide this TAD with hole. Personally, I have preferred to utilize the anchor plasmid screw from Myeongsang CNM company in South Korea for 25 years. During the final stage of TAD installation, it is crucial to verify with an explorer or a wire that the hole has been installed horizontally. With the main arch wire stabilizing the dental arch, the use of segmented wires allows for three-dimensional controlled force. So when moving the incisors, round wire is typically employed as the main arch wire, while the rectangular wire is preferred for molar movement. Segmented wire is primarily utilized the stainless 1/8 stainless steel round wire. Let's examine the biomechanics of the forward movement of the mandibular arch. While the open coil spring is pushing the incisor forward, it's both the main arch wire and segmented wire function in synergy to maintain the height of the incisors. Segmented wire and open coil spring serve as anchorage for the forward movement of the premolars. At this junction, it is also permissible to replace it with closed coil spring. When advancing the molars, so pulling from forward with TADs may lead on to extrusion of the molars and intrusion of the incisor as side effects. Therefore, so rather than employing a pulling strategy, stabilizing the incisors with segmented wire and open coil while advancing the molars maintains vertical stability for both the incisors and molars. I published the case report utilizing this device in the 2022 HAUDOCC. I have designed this TED-supported pushing force system as a lead spring. Now, let us explore another case employing the TED-supported pushing force system. This patient is presented with a subgingival fracture of a maxillary central incisor. Other than crowding, the patient has no complaint about his facial appearance. Due to the subgingival fracture margin, this prosthetic treatment was challenging, so prompting the endodontist to refer the patient to me. But orthodontic treatment options are peaceful. So we can create the space by moving adjacent teeth distally and extruding the fractured tooth for prosthetic intervention. However, I decided to extract the fractured central incisor and advance the upper right dentition. What would be the optimal method for effectively moving the right teeth forward without retracting the opposing teeth? If TED was installed in the anterior region, while pulling the posterior teeth forward, we may observe tipping of the pulled teeth, resulting in intrusion of the incisors, which could lead to a tilted occlusal plane in the anterior segment. Utilizing the pushing force of the respring allows for anterior movement of the teeth without adverse impacts. To expedite aesthetic restoration, we first push the lateral incisor forward, followed by major advancement of the canine. The use of pushing force facilitates more effective forward movement of the canine. After which we advance the remaining teeth. Employing the lead spring, I moved the lateral incisor and canines medially and successfully closed the extraction space of the central incisor. Subsequently, I advanced the premolar and molars medially. I protracted the upper right teeth by 1 tooth size to form a class 2 canine and molar relationships. Here, you can see a comparison of the treatment before and after. The medial movement of the upper right teeth resulted in an intentional asymmetric arch. The posterior teeth were adequately advanced to cross the extraction space of the maxillary central incisor without significantly altering the anterior position of the maxillary anterior teeth. Even after not wearing a removable upright retainer for 2 years during university entrance examinations, the position and occlusion of the anterior teeth were effectively maintained. Even after 4 years, we continue to observe a stable and functional occlusion. The position of the incisors and occlusion has remained stable for 4 years post-treatment patient. This many patient exhibit is class 3 with crowding in the maxillary incisors and discoloration in the central incisor. Although the patient perceives sleep protrusion, that he is not interested in orthoplastic surgery. Due to severe root resorption in the discolored maxillary anterior incisor, extraction was deemed necessary, and I decided to utilize the lead spring to facilitate the closure of this space. I extracted the discolored This maxillary central incisor along with the 3 premolars. To close the extraction space of the central incisor, I moved the lateral incisors and canines medially using the respring and retracted the mandibular incisors to create a compromised occlusion. I temporarily restored the lateral incisor that this was replaced with the central incisor using resin buildup and completed the treatment. Using the leaf spring, I facilitated the forward movement of the canines and molars while minimizing the retraction of the maxillary incisors to cross the extraction space. Although maxillary incisor required extraction, we successfully established an appropriate overjet and achieved a compromised treatment result. This data-supported pushing process system can be effectively employed in orthodontic treatment that involves only maxillary extraction. Following the extraction of the maxillary premolars, the incisors adequately retracted, resulting in a proper overjet. However, in certain cases may still present with residual extraction spaces. In such instance, implementing class 3 intermaxillary elastic can enhance overjet through the retraction of the mandibular incisors whilst simultaneously reducing extraction space through the forward movement of the maxillary molars. However, a common issue arises when the retracted mandibular incisor position relaxed, potentially colliding with the creating space at the maxillary incisors. If we can maintain the incisors in a stable position while effectively advancing the molars, post-treatment retention will be reinforced. Let's review a case that exemplifies this approach. This patient is present with class 2 malocclusion characterized by lateral incisor crossbite and midline displacement. Yet it reports no concern regarding facial aesthetics. While it is possible to move the entire maxillary arch backward with following the extraction of the third molars, I opted to extract the maxillary premolars to facilitate to improvement of the maxillary incisor protrusion and crowding. I anticipate that widening the space for the lateral incisor would lead the midline improvement. But the midline did not show significant advancement as the canine wall is displaced posteriorly. I had hoped that closing the extraction space would improve the midline. However, as overjet diminishes, it becomes increasingly challenging to retract the incisors. When the forward movement of the maxillary molars is less than anticipated, residual extraction space may arise, complicating further progress. I work space cautiously when it comes to the use of class 3 elasticity in such a situation. Utilizing the respring to push the incisors to the right not only improves the midline, but also enhancing the overjet in the anterior segment, facilitating its easier forward movement of the molars. This approach allows for straightforward alignment of the midline, and we successfully completed the treatment while utilizing anchorage to advance to the molars medially. Given that a tight overjet can breed a spacing of the maxillary anterior teeth during retention, I make sure to establish a generous anterior overjet. Thanks to the pad-supported pushing force of the respring, this was accomplished with ease. I positioned the maxillary inside favorably, is concerning the mandibular incisors, and is closed the remaining space with the forward movement of the molars. At 1 year post retention, the position of the incisors and occlusion of the molars will maintained and stable. Both oval and object has also remained stable, and I recommended the extraction of the third molars. Since it is unnecessary to compromise the oval and object of the incisors to advance the molars, we can achieve a favorable and stable incisor position during retention. The ease of moving the molars with the respling, so make it a variable tool, even in case of asymmetric tooth loss. This patient has experienced the loss of 6 premolars, with 1 missing on the left side and 2 on the right side. The mandibular midline is deviated to the right, so where 2 premolars has been lost. I decided to extract the remaining mandibular left primary molar and close the space to improve the midline and tooth axis of the mandibular incisors. However, if the mandibular incisors are shifted to the left, the space on the right will further widen, necessitating the forward movement of the right molars to reduce the remaining space. I opted to employ the respling to simultaneously enhance the midline flexion and forward movement of the right molars. By closing the space of the extracted mandibular left primary molar, I was able to improve the inclination and position of the mandibular incisors. At this stage, the respling can be employed to provide more precise adjustment to the midline and object. Once the position of the incisors shows improvement, so I can adjust the length of the open coil spring or replace it with closed coil spring to establish the anchorage for the forward movement of the molars. Considering the duration of the treatment and patient preference, we can determine the extent of forward movement of the molars. After symmetrical position of the molars, I left active space for the future implant in the area of 1 premolars. The severely resolved mandibular right second primary molar was lost. I installed a tab with a hole on the right side of the mandible. As I closed the primary molar extraction space and pushed the mandibular incisors forward using the lead spring, the mandibular midline gradually improved. As the mandibular midline improved, the space from the missing left premolar was closing. While stabilizing the incisors with the lead spring, I moved the right molars medially to establish a symmetrical molar relationship. Using CAD-supported pushing forces, I effectively reduced the space of multiple teeth while maintaining symmetry in the dental arch. The lead spring can be effectively employed when simultaneous movement of both the incisors and molars in the same direction is required. Even at 2-year post-treatment, the midline and occlusion was well preserved. Throughout our 2-year retention period, the improvement of the incisors and lips have been consistent and well maintained. Although the leftward movement of the mandibular incisors and forward advancement of the right molar occurred simultaneously, they were achieved with ease and stably through the utilization of TED-supported pushing force. This is another case of class 2 subdivision malocclusion. Although the object is large, its facial aesthetics and dental alignment suggests that extraction may not be necessary. I pondered about how to correct the midline deviation of the mandible and improve the class 2 molar relationship on the right side without resorting to extraction. Employing the respring, I improved the mandibular midline while advancing the right molars forward to establish a class 1 relationship. Utilizing a single tab, I achieved considerable midline improvement and successfully established a symmetrical class 1 occlusion with ease. 2 years of retention, this midline and molar occlusion has been well maintained. The class 2 subdivision malocclusion has shown significant improvement and is being stably maintained. The use of TED-supported pushing force allows for easy achievement of symmetry for both the incisors and molars. While the teeth shifted to attain symmetry, the collaboration between the main arch wire and TED-supported segmented wire ensures optimal stability throughout the dental arch. Respring capacity of easy molar movement while maintaining arch stability can effectively help clinicians to treat even patients with congenital anomalies. This patient who possesses a favorable facial appearance has lost 2 mandibular incisors. I hesitated to extract the maxillary premolars, and the patient expressed disinterest in undergoing implant. While the occlusion is not completely ideal, I decided to advance all the posterior teeth based on the positioning of the mandibular incisors to establish a compromised occlusion. I prioritized the forward movement of the mandibular canine to shape the anterior region before advancing the premolar and molars. To ensure an appropriate overjet, I slightly retract the maxillary arch. The treatment is concluded with a compromised occlusion exhibits a full step with prominent class 3 molar relationship. The TED-supported pushing force of the respring facilitated an effective forward movement of the mandibular arch. By centering the position of the mandibular incisors, I advanced the maxillary molars backward. I successfully moved the mandibular molars forward while maintaining the position of the mandibular incisors. I applied the same treatment methodology for this patient who has lost all 4 incisors. There were several space issues in the incisors and premolar area, despite the presence of the remaining primary teeth. To avoid the prosthetics in the missing region, I opted to advance all the molars forward. By installing lead spring in all 4 quadrants of the upper and lower arches, I pushed the canine forward to cross the incisor space, allowing in some retraction of the maxillary incisor. I then proceeded to advance the posterior teeth forward. The forward movement of the molars effectively resolved the space in the incisor region. The appearance of the rib improved, and a compromised occlusion was reestablished with appropriate wide and overjet. This treatment was conducted smoothly during a sensitive adolescent patient when cooperation for maxillary elastic use was difficult. Without patient cooperation, the posterior teeth were effectively gathered forward. By adjusting the overjet relative to the mandibular incisor, I successfully advanced both the maxillary and mandibular molars. While closing multiple spaces, I effectively aligned all the teeth to create a satisfactory occlusion. The forward movement of the teeth resulted in significant widening of the retromolar area. This patient is visited a general dentist for implants due to the loss of the mandibular first molars. However, the dentist recommended orthodontic treatment and reported the patient to me. The patient who had not considered orthodontic treatment primarily desired the forward movement of the mandibular molars only. After stabilizing the mandibular incisor region with the respling, I advanced the second molars measure, which allows for the eruption of the third molar in that area. Subsequently, I advanced the third molar visually to replace the missing space of the first molar with the posterior teeth. With the respling stabilizing the incisor region, I first advanced the mandibular second molar forward. Afterwards, I visually advanced the third molar that has sufficiently locked it. While advancing the mandibular molars, the position of the mandibular incisors was stably secured due to the anchorage provided by the respling. The absence of the need for intermaxillary elastic assistance allowed for effective forward movement of the mandibular molars without reliance on the maxillary appliance. The stability of the mandibular anterior segment was preserved independently of patient cooperation while achieving effective anterior movement of the posterior molars. As I mentioned at the beginning of the lecture, treatment that cross space asymmetrically can negatively impact the stability of the dentition. In such scenarios, I'd like to present a case where the child-supported pushing force has been applied effectively. This patient presents with deep ovite and overjet, exhibiting class 2 occlusion. Notably, the mandibular right second premolar were congenitally absent. There is evident protrusion of the upper lip and absence of the mandibular premolar. We could consider extracting 3 premolars from other areas and retracting the incisors. Or we could plan for implant in the missing region without extraction. After discussing with the patient, I decided to move the entire maxillary enlarge backward while advancing the right molar, mandibular right molar, to close the missing space. I installed the bite block on the maxillary canines and proceeded with the leveling. Following this, I placed the respling and initiated the forward movement of the molars. Thanks to the anchorage provided by the respling, the forward movement of the mandibular, the forward movement of the mandibular right molar is progressed smoothly without requiring any movement of the incisors, leading to the formation of an intentional full class 3 molar relationship. The forward movement of the mandibular molars resulted in a satisfactory occlusion achieved thoroughly with the patient's own teeth without the need of need for implants. I anticipate that the third molar will erupt later and contributed to the region. The space for the congenitally missing premolars has closed well. Unfortunately, the third molar are erupting with a major inclination. Once they have erupted sufficiently, improving the alignment of the teeth is not difficult. In scenarios where significant change to the position of the incisors are unnecessary, but forward movement of the molars is required, the leaf spring is enabled in such a movement without demanding patient preparation. What if there is a need for movement of the incisors? This female student has two missing mandibular incisors, along with lingual inclination of the incisors and a pronounced overjet. Although there is a slightly mandibular asymmetry, her facial aesthetics are generally favorable. The position of the maxillary incisors and lips are relatively well aligned. However, the overjet is notably large. What option should we consider? Extracting the maxillary premolars and retracting the incisors may compromise her facial aesthetics. So, I decided to attempt to advance the entire mandibular arch forward as a non-traditional approach to avoid the extraction or prosthetic intervention. I installed a V-spring in the mandible and pushed the 6 anterior teeth forward to improve the overjet. After achieving the desired overjet, I adjusted the pad to apply vertical forces for enhancing the height of the mandibular anterior segment. By advancing the mandibular incisors, I successfully improved the overjet and made vertical adjustment to establish a normal relationship of overbite. An intentional class-free compromised occlusion was established. Throughout this process, we maintained a favorable facial appearance while achieving normal overbite and overjet, successfully completing the treatment. I have high hope for the successful development of the mandibular third molars. Here is a comparison of the saprophometric and panoramic radiography before and after treatment, demonstrating remarked its improvement in the mandibular dentition. The TED-supported bridging process system is beneficial not only for advancing its incisors, but also for vertical positioning, facilitating the establishment of the normal overbite and overjet. Given that these patients were still in their growing phases, I believe this approach proved is particularly effective. The ease of advancing the mandibular incisors is also advantageous for patients preparing for orthodontic surgery. If class-3 malocclusion progresses, it often involves lingual inclination of the mandibular incisors, which can be effectively corrected with the TED-supported pushing process system. This patient, who is preparing for orthodontic surgery, is present with the skeletal class 3 malocclusion due to excessive mandibular growth. It is crucial to decompensate the retroclined mandibular incisors prior to surgery. Utilizing the TED-supported pushing procedure respring to advance the mandibular incisor simplifies the process of restoring their inclination. This approach is more direct and effective compared to top application on the arch wire. I successfully restored the inclination of the mandibular incisors with the respring, facilitating a smooth execution of the orthodontic surgery. Post-surgery, the patient achieved a harmonious and balanced facial appearance and interdental relationships. Even 2 years after treatment completion, the result maintained stable and favorable. Throughout this time frame, the inclination of the incisors has been properly maintained. The TAD-supported pushing process system can also be utilized during the retraction of the whole dental arch. When the entire arch is moved backward, there may be a tendency for the molars to intrude, leading to a potential posterior bite or deepening of the anterior bite, which could be detrimental to treatment outcomes. However, in such instance, employing TAD-supported pushing force to push the molar back can prevent intrusion and prevent this unwanted side impact. I'd like to conclude my lecture. Connecting the TAD with the sectional arch wire to the main arch wire can provide three-dimensional stability to the dental arch. With this stability, so we can achieve three-dimensional tooth movement in situations such as crash tooth subdivision. Improving the midline need not be a concern. Based on stable anchorage of the incisors, so we can achieve desired molar movement across various extraction and missing tooth scenarios. Three-dimensional adjustment of the incisors are entirely feasible. I hope that the TAD-supported pushing force system will significantly enhance your orthodontic practice. I'd like to thank you, Dr. Jung-Ju Park, for assisting with the lecture preparation, and Dr. Hyun Eun and Dr. Hai Ban Giap for their help with the Vietnamese subtitles. If you have any question regarding the lecture, please feel free to email me, and I will respond. Thank you for your attention. Please come on.
Okay, thank you so much, Professor Jo Jong Lee. So perfect and useful cases. Thank you so much.